Good afternoon and welcome to Beyond Import-Export Holistic Data Migration Approaches, a webinar tweet chat combo from healthsystemcio.com sponsored by Galen Healthcare Solutions. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. You can use that to send in your questions as they occur to you. Leave the default set to all panelists. We'll take those later in the program, but again, send them in as they occur to you. And you can download the deck by using the URL on your screen, and it's the bottom of our slides. Just so you see how we're going to spend our time today, first we're going to have our panel discussion featuring Ream, Senior Director of Applications and Chief Information Security Officer with the Cambridge Health Alliance. Richard Temple, VP and CIO with Deborah Heart and Lung Center, and August Borie, Lead Technology Consultant with Galen Healthcare Solutions. So let's jump right into our discussion. Art, can you start us off by giving us an overview of your organization and role?
Sure. Cambridge Health Alliance is a 3-hospital system in the city of Cambridge. We're also the Public Health Commission for the city of Cambridge as well. So we're a nonprofit quasi-public entity with 15 primary care clinics. Going to go to 16 this month, opening another one. We have a significant behavioral health population and business teaching hospital for Harvard and Tufts. And my role here is the Senior Director of Applications. I handle all of the applications portfolio as well as the Chief Information Security Officer.
Excellent. Very good. Rich?
Good afternoon, everybody. My name is Rich Temple. I'm Vice President, Chief Information Officer of Deborah Heart and Lung Center in southern New Jersey. Deborah is a cardiovascular specialty hospital, and one of our claims to fame is that we are actually one of only 3 hospital systems in the country that will never send a patient a bill as part of our mission. So it adds a very interesting dynamic, but it is very gratifying to know that we can be part of something so impactful in terms of helping people get access to care who otherwise wouldn't be able to.
Excellent. Thank you, Rich. August?
Sure. August Borie. I'm a lead technical consultant with Galen Healthcare Solutions. Galen is a class-leading healthcare IT technical and professional services group. We provide services and solutions for a wide range of organizations, really with a significant focus on organizations that are going through an EMR transition. Personally, I'm part of the larger transition team. We specialize in kind of the 4 pieces of the transition to an EHR. You've got legacy application support, the data migration itself, then the target system implementation. We focus on Epic, Cerner, Meditech, and Allscripts, and then finally the 4th is archival. And then also in addition to being on that team, I work as a developer on our migration platform, which is called Galen ETL.
Excellent, August. Thank you very much for that. Okay, Art, let's start with you. One moment. Can you give us an overview of some of the data migration projects you've headed up? Art?
See, I was just testing you on that mute button.
Oh, you know what? The inside joke here, people, is many folks put themselves on mute and forget to take themselves off, and I think that's what my friend Art just did.
So just to kind of, chime in on that, we have done several migrations here. We are an Epic and Meditech shop, so started out as Meditech and went to an Epic shop. So when we brought on our ambulatory units, and some of our clinics, we had to move the data that was in the ambulatory model in Meditech over to Epic, which was, an export and an import kind of data migration and mapping processes. Currently, right now, that was our larger project, but currently right now we're in the ACO in Boston here, with Beth Israel Deaconess, and we are in a process of migrating claims data, which is becoming a challenge trying to ingest that and the files that are associated with that, even with the same payers, but different sources, we end up with mapping and changes that are starting to be quite a challenging process at this point in time, because none of the files, albeit they say are standardized, are not. So it requires a lot of manipulation of the files. So that's some of the heavy stuff that we've got going, or did have going as well.
Okay, good. Looking forward to getting into more detail on that stuff. Rich, give us an overview of some of the data migration projects that you've headed up or are heading up.
I've had a number over the years, but there's one that's very close to my heart because we've just gone through it, and that is our organization has just migrated from Meditech client server version 566 to Meditech version 615, and although both are Meditech, it is in essence a rip and replace. It's like a new conversion and a new implementation, and we converted as much data as we practically could from the old system to the new system. We did an MPI conversion, we did a detailed revenue cycle conversion line by line, which anyone will tell you is grueling, and I can personally attest to that. It is very grueling, but we really didn't want to leave the old residual system out there in any form or fashion other than for just accessing historical data on. We also converted on, we did an abstracting conversion as well, things like problem lists, those came over. Another interesting thing we had to do or attempted to do was, although we were a Meditech shop on the hospital side, we were all scripts on the ambulatory side, and we migrated from all scripts onto Meditech's web ambulatory platform. And we had originally intended to actually move over all of the future orders so we could activate those orders for ambulatory appointments in Meditech, but that turned out to actually be somewhat messy for a number of different reasons. It was so messy, in fact, that after we did it, we backed it out. And the reason we backed it out was that we had orders for doctors who were no longer affiliated with the organization. They were just chock full of different things that were making it untenable to use. So although technologically we were able to get the migration to work, in practice it really didn't pan out. And I think that's an important lesson that anyone who's contemplating a large-scale data migration should think about. Although you may be able to dot the I's and cross the T's on the technology, it has to be able to fit into workflow and it has to be usable. And oftentimes the people and process piece winds up being much more cumbersome than the technology piece is. And that's not to trivialize the complexity of the technology piece. It is very complex, but that three-legged stool has to make sure we have the others covered as well, or it's not going to be successful.
Very good, and I think we're going to bring up that topic of fitting into workflow a little bit later. Very important issue. All right, next question. All right, let's start with you on this one. Were there any auditing processes used with regards to extracts, mapping, data loads, etc.? Did you use automated validation tools or sampling techniques in your validation step?
So we didn't use any tool set. It was more of a human, what we mentioned earlier was the human abstraction of like problem lists and stuff like that, but the general electronic data that came over, once we put that into the newer system, we would do a comparison between the two systems, and that was largely the analyst. It was not an automated tool to match one for one or look down across that. So from the claims data perspective that we're dealing with now, that is also a manual process. We didn't employ any technology to double check that or QC that at this point in time.
Okay, Rich?
A hybrid of both, I would say, in migrating from our old version of Meditech to our new version of Meditech. Meditech does offer some tools that one can use to validate. Meditech actually does, in some cases, an initial validation and leaves it to us to sort of do the heavy lifting on a case-by-case basis. So to the extent that we had those tools, we leveraged them. We did some large-scale conversions. Actually, go back 10 years. So we would do we do 1 year in a secondary test ring for starters, make sure that balanced, and move that over. Then we do a second year and move that over, et cetera, et cetera. However, there were not automated tools for everything that we wanted to do, and we did fall into doing a representative sampling of before and after to make sure things tied. Ultimately, I think we wound up being very successful in it, but not without a lot of blood, sweat, and tears.
Mm-hmm. Very good.
And I'll just kind of add on to what.
Go ahead.
Oh, sure. I was just going to add on to what Art and Rich mentioned in terms of kind of doing that manual validation process. We've definitely found that and spent a lot of time on our validation methodology when we go through a data migration. And while we can leverage certain types of tools that we have, such as validation scripts and different testing methodologies, we really want to focus and make sure that we're being as in-depth as we can with the validation, and that, like they mentioned, the data is usable in the system going forward. It's one thing to validate the data, but if it's not going to be usable for the end user, kind of what's the point? So just kind of attesting to that fact as well.
Excellent.
And even building on it.
Go ahead.
And even building on that, what we found in a couple of cases was that although the before and the after technically reconciled, the whole process of validation uncovered the fact that not everything that we had in our before was entirely charted correctly. So we were able to sort of flush out a couple of interesting process issues and get those addressed. So it's even more than just validating and making sure you have a like-for-like comparison. You really got to go into the weeds and make sure that everything that's in the before belonged in the before.
Excellent. Very good. All right. Next question. Rich, let's stick with you. What formats or standards were used for export and import, and were there libraries that were leveraged?
Well, we did some work in HL7 because we were going from an older version of Meditech to a newer version of Meditech. There were predefined conversions that ran that would not necessarily fall under the rubric of HL7 or anything like that. However, we took what we had in that regard. But on the other hand, we also wanted to make sure that we could seamlessly continue to interoperate with our health information exchange. So we wanted to be able to send CCDs out and other things. So that was an HL7 thing, and that required rather extensive testing because you've seen one version of HL7, you've seen one version of HL7. So you do want, even though we had what were deemed to be reusable conversion paths, it didn't cover everything, and we did have to retrofit some of the HL7 work that we did to interoperate with the outside world. So we touched a little bit of everything, I'd say, in answer to that question.
Very good. Art?
Yeah, so much to that point, we did some HL7 conversions, keeping in with that standard, but largely a lot of our ingestion was done by, believe it or not, Excel spreadsheets, which have defined fields, and then in the EHR, there is defined protocols that map those fields into the appropriate database fields, and we would ingest that into the system and then validate from that. So that's kind of it was odd to me, but it actually works actually kind of quite well for validating and looking through the data, in a spreadsheet. But it actually does work pretty seamlessly, provided you design the imports methodology, the imports parameters inside the receiving EHR correctly. You can certainly map fields differently or backwards, but with a couple of QCs in a test environment, you can, double check that.
August, thoughts?
Sure. So, both Art and Rich mentioned HL7 and CCD. I'll just kind of add that CCD is one that we've used quite a bit, generating what we've called sort of a custom CCD. It's based on a standard format, but it's a robust CCD that we've used to, to import into various target systems, and kind of adding in a lot of information that CCD might possibly be missing. And so we've found that over time that kind of using that standard, using that approach has worked really well for helping end users when they're reconciling that data, kind of taking the data from the CCD, importing it into the target system, really reducing the number of clicks and reducing their workflow when working with that data.
Excellent. All right, next question. Rich, how did you decide which data to migrate and which to leave in the legacy system or archive?
Great question. One of our overarching goals in migrating to a new EHR, other than making sure we're ready for meaningful use stage 3, was we really wanted to be on one platform across the board. I mean, we were Meditech on one side of the fence, and we were Allscripts on another side of the fence, and we had a little bit of IDX thrown in, and there were many different systems that were talking to each other, sometimes not as well as we'd like. And one of our goals was to be on a single platform. So that made the decision about legacy system simple. There was not going to be a legacy system anymore, with one exception. So we wanted to move over as much as we practically could, in making sure that we had data ready for legal retention purposes, making sure we abided by all the regulations with regards to that. So we do, however, we moved a lot of data over. For the data that we didn't move over, we actually still do have our legacy system open, but we're able to invoke it through both the Meditech acute ambulatory product, acute EHR product, as well as the ambulatory product. What you see when you invoke what they call the historical data link varies, whether it's acute or ambulatory, which is an interesting, again, another one of those workflow challenges to how do you get the most data in the easiest way possible pushed to the person who needs to see it. But long and short of it is that we basically went to great lengths to minimize the number of systems we had out there and wanted to push our legacy systems out as quickly as we could.
Very good. Art?
Yeah, we haven't, or we don't have a legacy system. So in other words, you've got Meditech and Epic running together here with the majority, if not all, of the clinic-facing functionality and data sitting in Epic, and the administrative and or ancillaries sitting in Epic. So when we migrated some of the ambulatory stuff off of Meditech, we put the clinical data, that was our decision. What was the most relevant clinical data that we wanted to abstract and or move over, so that we had the forward-facing of Epic, and then the medical records system and the billing, as well as the ancillary diagnostics, would receive the orders and pass them back, obviously, through an engine that way. So it was the core of the patient's demographics. It was the core of the patient's problem list, allergies, things like that, and any notes that we could bring over. And at some point in time over the next year and a half, we will sunset part of or most of the Meditech system, with the exception of one ancillary and the general financials. So that will be what's over there, and it will remain as a core reference. So we'll be able to look back at it, but we're not going to publicly move it forward.
All right, very good. Art, let's stick with you here. Were there data elements migrated above and beyond what HL7 standards supported? I think you answered that to the affirmative.
Yeah, I mean, there's certain fields and certain things that don't move over through HL7, and then some custom designed fields and everything that we actually wanted, so that we would move those through the Excel spreadsheets and populate them into the existing fields that we wanted. Okay,
very good, Rich. I think you said yes as well.
Yeah, same thing. I concur with Art in terms of how we did our migrations. I mean, Meditech had pretty detailed migration paths that go well beyond what HL7 supported, but we did use HL7 where practical and where it was able to get us to what we needed.
All right, very good. We'll stick with you, Rich. Was data migrated into an existing EMR, and how was reconciliation handled?
Well, it was an existing EMR insofar as one that we were building from scratch. So going from old Meditech to new Meditech, it really is a new EMR, and reconciliation was handled. Number one, where available, using Meditech's validation tools that they share with us. Number two, either sometimes Meditech would do an initial validation and we do a backup validation. Sometimes we were on the hook to do the validation. And there were other times where we really had to do our own validation, and it wasn't. I would say even in those situations, it wasn't terribly onerous, but we did have to do it.
All right.
We've had both EHRs, so yes, it was existing at the current standpoint. I think the first entity that came up, or the first division that came up clean, with a hand abstraction of the charts from that individual ambulatory clinic. The ambulatory came up first on our EHR, and then successively after that, it was various HL7 and or the imports that we did, and largely the reconciliation was a look at the chart here, look at the chart there, and it was a validation between both administrative staff for the administrative items in the chart as well as the clinical staff. And it was largely, in some of the ambulatory clinics, the actual providers that had that patient panel in that clinic, they knew their patients well and would look at that data during the conversion.
Very good. What types of clinical data elements were migrated, Rich?
For us, we have diagnoses, problem lists. As we had attempted to bring over future order information on the ambulatory side, but decided not to after we saw some of the challenges that manifested themselves when we actually looked at them on the other side. So, and one of the things which is interesting is that you could bring it's very helpful from a physician's perspective to bring over things like problems and allergies and wherever practical and those sorts of things. You can also provide too much information where a physician could absolutely be bombarded by problems, and the physician might be seeing problems that don't pertain to the specialty of that physician or the reason why the patient is presenting on a particular day. So there could be, it's important to bring over as much as you can, but it's also important to be judicious about what you're bringing over, so you're not drowning the physician in data to the point that they really can't pull anything actionable out of it.
Now, Rich, how does the IT professional find out what data is needed by what physician, by what specialty at what time? Are those steering committees and things like that get you that information and you go out and then make it happen?
There are indeed. We had a very robust PAC, a physician advisory committee, with really excellent physician representation. We had our clinical informaticist who was on that committee. We had our physician informaticist who participated closely. A fair number of the people who are analysts who are supporting our clinicians day in and day out are clinicians themselves, RNs or what have you. It's just important to build those relationships. It's important to make sure that the doctors have a forum for articulating what their needs are. It's important that we have also a forum where we can pose questions and demonstrate what things look like and say, is this going to work for you? In point of fact, sometimes you don't know for sure what's going to work for you until you're actually using it in a live clinical setting. It may look good in tests, but practically speaking, sometimes it may not be good when you're cranking through many patients a day and hitting these little log jams. So having that dialogue, having governance, making sure that physicians, nurses, and other clinicians are heavily involved in the build. We had different core teams, all of whom had a significant clinical presence. Making sure the right people are talking to the right people, and that from an IT side, we're listening and we're acting.
Art, the question on the screen, what types of clinical data elements? And then if you also want to touch on what we added on with Rich about making sure you really understand what the physicians want, so you don't move ahead and create an environment that they say doesn't work for them, And then also, I would imagine that you've all encountered situations where, as Rich touched on, they say, well, yeah, this is what we want, but then when you actually do it, it's not exactly what I want. And then you have to go back and change it. Any of that stuff, Art?
Yeah, sure. Much to Rich's thing, tests and development, or whatever you particularly call them, always look fabulous, or at least to us lay people. So, and we think we've got the best product in the world. But I guess I can say I'm pretty fortunate in that regard. Before moving, inside of my group, I have a informatics group, which I'm blessed to have full-time 4 doctors, hospitalist, ambulatory. ED physician, all of which practice inside the organization, and a specialist, as well as a pharmacy informatics, 3 of those, and 4 nursing informatics. So from a well-rounded, they were part of the migration team. They understood what was going on, what the chart should look like, and they're all practicing, as well as IT individuals that do build in the system and move things with all of the other analysts. So the fortunate position that I'm in is that can be looked at, and that can have the individual discussions up front with the with the constituents that are in each individual area, because they're in touch with it and they practice in it. So they don't make assumptions, but they have a conversation with their colleagues, and we come back with the migration process. Was it always perfect? Absolutely not. Did they find out the It's very easy after you get the data in there to, much what Rich says, is there's a lot of data in there. There's overwhelming amount of stuff staring at everybody in the face all the time. That will be true even if you didn't migrate anything at some point in time in your EHR. They're starting to get very busy. There's a lot of information that's sitting on one little screen that you can get to just about everything. So over time that will happen, but if you put the useless data up there at first and don't QC it and understand it, there's less confidence in the system and say, I just can't use this because I just don't need all of this, this, and this. So I was fortunate in that regard for that perspective.
Yeah. And you do have to be, as an IT lead, you have to be super responsive, because inevitably when you go live with a new system and you go live with new workflows, there's going to be resistance. There are going to be issues that pop up, and people as people encounter problems, they get frustrated. They're trying to take care of patients, and they don't want the system getting in the way. So it is of the utmost importance that IT is like right there at their elbow, helping them any way they possibly can. And I think they build a respect, and we want to continue to have that sense of partnership. So I mean, maybe things aren't going to be perfect out of the box, but we know that you're listening as clinicians. We know that you're listening to us, and you're going to make it as right as you possibly can.
And one of the things that we've definitely encountered on many projects is kind of the scope, can change as the project moves on, as it morphs into what's going to be the most helpful for the clinicians, looking at that data in the target system. So sometimes getting on the phone, having meetings, actually running through demos of, okay, here's the data that's in this test environment, go play with it. This is how these workflows are going to work. And then you might get oh, well, this actually isn't going to be as helpful as we thought it was going to be. Maybe we'll cut this one element out and then add this other element over here, things like that. So it's almost kind of like a fluid process as we go through the project, but you have to be flexible and just kind of incorporate different needs as they arise.
Very good, very good. All right. August, let's start with you on this. What options were considered for patient matching, and how were exceptions handled? Just talk generally about projects you've worked on regarding patient matching.
Sure. Well, to start off, it kind of depends on whether the system is already live or whether it's a brand new implementation. As you can imagine, when you've got a system that's already live, you might have a percentage of overlap between the patients that are existing in that system and then the ones that need to be added. So in general, we try to focus on the core kind of elements, first name, last name, date of birth, SSN, and gender, to really hone in on whether we're matching to the correct patient or not. We don't want to have any question about whether this is the correct patient to match data to. We don't want to go down that road. So if the legacy system's medical record number can be brought over via an MPI load or something to that effect into the target system, that's certainly helpful. but we like to focus on the main items, have a threshold that needs to be met, and then move forward with the exceptions from there, and usually get some input from maybe the HIM team or another team that's comfortable and used to working, patient validation or patient questions, things like that.
Very good, Art.
Yeah, much to the comment a few minutes ago about the HIM team. I think I've been remiss in actually including them or even mentioning them all along the process, since potentially, or actually not potentially, they do own the legal medical record, and what you're putting in there, we did have them on the physician informatics group that would look down through the charts, evaluate the charts, because they own the paper charts. They're responsible for the legal releases and what might be questioned or not questioned. So it certainly had sign-off from them, and I think that's the biggest comment I can make here.
Rich?
I would echo Art's comment about the incredible importance of the HIM department. I mean, our HIM department is front and center of everything in terms of validating, in terms of conversions, in terms of making sure that workflows and the right reports were appropriately pulled over to the legal medical record, things like that. That's a biggie. We also, because we were migrating from one Meditech to another, we were able to use our medical record number, in essence, as our MPI number, and that was our match. We don't always have that luxury. There are times we have to do what's called probabilistic matching, where you'll have a name and date of birth, and it could be Rich Temple or Richard Temple, and same date of birth, and it can go to a report, and people have to go and manually match that. We did have a lot of situations post-go-live where we had to do ad hoc merges after the fact, and a lot of those ad hoc merges came as a result of reviewing kick-out type situations where names may have been similar, or things may have been close across two different records, but they were in point of fact the same person. So having an algorithm for probabilistic matching is important, but also having in your brain how you're going to probabilistically match and say, yes, this is the same person, are huge. There's just no way you're going to get around completely having to go in there and correct errors.
I think, I need to add to the data stuff that one thing that, kind of caught us off guard, which we really didn't catch, but, we caught, but and had to correct and strategize around is gender change patients and that type of a flag in the system. When you start to move those flags like that, let's say they were of one gender at the start of the of the existing data, and then since we had the EHR up before, and now we're moving some of that data in there, and they get flipped to another gender, what often happens is that often, while it shouldn't, it does affect your ancillary systems such as labs. It flips the it can flip and play havoc with the reference ranges on the lab instruments and stuff like that have to be noted and paid attention to. Certainly the provider that's caring for the patient understands that, but we really had to take a close look at every one of those flips during the course of migration.
August, any thoughts on the whole gender issue? Is that becoming more and more of a concern for people to deal with properly?
Yeah, that's a good point. What we've kind of seen in some of the projects that I've been working on most recently is that the gender is not always of the greatest use when attempting to match to the specific patient in the target system, because it can be either flipped or it can often just be marked down incorrectly by accident. So we've kind of focused more primarily on the heavy hitters, the name, the date of birth, social security number, things like that, and focus less on the gender. If it's nice, or if it's there, it's nice, but it's not, doesn't have to be as weighted as heavily as some of the other ones.
Excellent. All right, I want to jump to a little audience Q&A now, because we've got some interesting questions that have come in. So, Art, let's start with you. Let me throw out this question. In many organizations, the migrations needed are on the ambulatory front, and yet traditional HIM teams focus on their responsibilities in the acute setting. How has your organization overcome these record retention ruling calls, et cetera?
Yeah, originally, so we were of the, much to that question, most of our ambulatory medical records were housed in the individual the clinics, and they were responsible for that medical record. It was during the course that we decided to switch over EHRs and become a primary into, our current EHR, that we actually moved the obligation or the responsibility of the medical records department, or HIM, which falls under IT. That leadership took responsibility for the entire medical record, including all of the records that were in the ambulatory clinics, and they precipitated the transactions of absorbing them, either being scanning, because I forgot to mention that earlier, of documents into the current EHR. They took over the responsibility of that chart. So in light of that, we had, yes, most of the time before we started with the current EHR, HIM was primarily focused on the acute care medical record, and the individual records in the clinics were managed by them. Now it is one department, one person that's over that for the entire organization, and that transformation took place when we started to do the data migrations.
All right, very good. Rich, your thoughts on that question? Let me know if you need it reread.
Sure. No, I can answer that. Our world's a little bit different because the preponderance of our ambulatory volume comes from the clinic that we have right here on site at the hospital. Our patients check in the same place, and ultimately most of the data from the ambulatory side flows in some form or fashion into the acute system, though not without bumps. But there were separate systems out there, and to be able to, this is actually a big one, when we started billing, when we started processing and billing ambulatory under Meditech, all of a sudden there were exponentially more accounts created within the Meditech system. So there were workflow issues in terms of identifying the right account to chart on. So if you figure if you're an inpatient and you're in for several days, and there's a physician component for the consults that are done. There's also follow-up visits that take place, and there's an account for the technical component side, and there's an account for the physician component side. And it's very easy to wind up pulling the wrong account and charting on it. We have a couple of other unique aspects to us that further exacerbate that. But it's tricky because medical records winds up bearing the burden of that in terms of having to do a lot of merges, having to find ways of making sure that we can have every possible chance to zero in on the right account, because there was a little, we're much better at it now than we were out of the box, but it was a challenge initially and continues to be to some extent to this day. Just so many. Each patient now, when you bring up their record, there are just so many accounts associated, so many different encounters associated with it.
Very good. August, you want to touch on the audience question?
Sure. So, one of the clients that I've been working with relatively recently kind of has gone through that same sort of, not problem, but the same thing cropping up where the clinical data, we've been migrating the ambulatory data from a variety of ambulatory systems into, it's been epic. It's going to be the unified medical record, but we've had our struggles actually getting in contact with and kind of pulling in the HIM team to help with some of the patient merges, some of the kind of patient analysis that needs to get done of the ambulatory data, because there's been a little bit of a disconnect between who owns the data from the practice perspective and who owns the data from the acute perspective. So that's definitely been a challenge in the current projects I'm working on, but I think we're working through it, and there's starting to be kind of more of a unified presence in terms of kind of owning that data.
Okay, very good. Art, let's start with you. What record retention, e-discovery, and/or other information was used to define both the legal and the transaction or workflow requirements to define the data conversion plan? We have taken many approaches, and not one has resulted in a satisfactory result, especially in supporting the clinical workflow.
Now that's quite a question there. So
you can punt it. We'll throw it to Rich if you want. We'll put him on the top.
No, I don't want to punt it to Rich, but right. I mean, we actually followed the direction of HIM, and I can't honestly say I know exactly what standard they did. I'm assuming the legal medical record definition that they came up with in the state. and where they would have to publish that was, their directive and what they wanted to pull over. We still have all of the data that's out there accessible, so it's almost, we didn't lose anything and we didn't leave anything behind. We still have access to it, so that's where my concern is I don't think I have a really good, complete answer for that one.
All right, Rich, you want me to read it again, or you got it?
No, I think I got it. The rules are the rules, and our HIM folks are very, very acutely aware of what they have to retain and for how long, and we're very concerned that as we migrated from a different vendor's ambulatory EHR onto our current one, that there was a way of accessing the information from the former ambulatory system, and what we wound up doing was building, in essence, a local copy of our old, it was all scripts, our old script system, and that is available for as long as we need it. We've also taken pains to move as much information from the old system to the new system, so it's readily available. Everything is going to be right there, or not right. Everything is going to be available in terms of anything that we would need for an audit, for complying with legal retention requirements. We'll definitely be good on that front. Our goal was to push as much data as we could into the new EHR, and even now we're still pushing things from our old system to our new system to really reduce the need for people to go and look at the old historic system. So that's another data migration thing too, is moving reports, results, et cetera, from the old system to the new system, and there's a lot that goes into that as well.
August, do you have any thoughts on this issue?
Yeah, so one of the things that we've kind of seen a lot recently is when working with clients who are going through a migration is really focusing on bringing over the amount of data that's going to be required or that's needed to provide a continuity of care for the patients that are going to be on the new system, and really trying to hone in and focus that scope, just like Art and Rich had mentioned, so we're not overloading the chart in that new system, and so it's not difficult to find what you're looking for. Providers aren't having to sift through years and years of data, and then with the data that's not being brought over, focusing on archiving that. So bringing that into our archival solution and having a single sign-on from that new system, from that new EHR, right to the data that's in that legacy system, in case it does need to be referenced at a later point in time. So really having easy access to the data that's not brought over, and then also having, obviously, easy access, because the data is in the EHR, to the data that's going to help provide that continuity of care.
Very good. To you, Art, is it your plan to continue to pay to keep up your legacy systems indefinitely?
So we have a set fee that we've paid. We will eventually, once we pull past the regulations, number one, probably discontinue that. So like imaging and stuff like that we'd actually want to keep, we move the pointers over. So in other words, I still point to all of that data. And at some point in time, the discussions have ensued, outside of the regulatory requirements, but from a clinical perspective, at some point in time, some of that data, if not the majority of it, and this is the opinion of informatics and the general provider population, it becomes clinically irrelevant. At some point in time, we would archive that and or just keep the archive of it, but it becomes non-helpful during the course of a treatment of a patient after a certain given point in time. I mean, it's, somebody described it to me as overcome by events. At some point in time in your care, that becomes irrelevant. They don't look back that far for certain things. Images and other things like that from radiology and stuff like that, certainly there's a history there. The cancer processes and the lifetime dosing and stuff, all of that needs to be considered. But, there's certain parts of that are not applicable.
Very good. Rich?
We're still hosting our legacy system, but it's only accessible, with a few exceptions, it's only accessible through the new system's historical data link. And we don't have any specific timetable that we're looking at for sunsetting that. I think as we continue to migrate as many reports, the conversion of as many reports as we possibly can that we didn't do in the initial run over to the new system, I think it'll become less and less of an issue to maintain that. It's not costing us a fortune because we're hosting it on-prem. We have just the minimal level of support that we need. It's read-only with a very few exceptions. So it's not a huge bear for us, but at some point it just would make sense for us to let that go. But we don't have any specific timetable for that right now.
August, what are you seeing out there in terms of people that have migrated? I guess the concept is trying to end that expense to the old vendor at some point when they can.
Right, yeah, and at some point is sometimes not always as soon as people would like, I'm sure, but that is definitely what we're seeing, you know, that not wanting to continue those licensing costs, even if they're, you know, they can be sometimes, you know, not too much of a bear in terms of if there's not that many users accessing those systems, but at some point kind of being able to recoup that hardware and being able to bring, you know, those costs down. And so that's kind of where that archival piece is coming in. And sometimes it's 6 months or a year, even 2 to 3 years after that system has been, or the data has been migrated for that system. So we've kind of seen a variety of things, but yeah, it definitely seems to be wanting to kind of at some point sunset those and move on to bring them into an archival space.
Very good. Rich, question from the audience for you. Was the Meditech migration from 5.x to 6.5 expanse to their cloud platform? Were additional network connections or bandwidth increased for the data migration? Any automation or use cases for getting the data out of the Meditech cloud, if applicable? And he offers a clarification to the question, were direct network connections from the legacy Meditech on-premise system to the Meditech cloud required for the data migration?
Yes, to some extent there was all that. We initially hosted our old 5X on-prem, and our new 6.1 is hosted in the cloud. So yeah, there was a whole lot of work that had to happen to allow for those connections to happen. It's still on, you know, it still runs on our network certainly. And there were circumstances too, I hope I've answered this question correctly, there were circumstances also where we had to have our cloud vendor do a point-to-point with certain of our business partners because you know, we were having collisions trying to work with our existing on-prem interface engine with data that's hosted in the cloud. So there are a lot of moving parts that go into this, and my goodness, I could talk for hours about this, but you probably don't want me to. But it ultimately worked out quite well. But you know, I think, as I said with other things too, not without a lot of blood, sweat, and tears. There's a lot that goes into, you know, hooking our old system to our new system, and also because we have a direct link from our remote hosted current system to our on-prem old system, there's a lot that has to support that so it comes in as seamlessly as possible.
Very good. Next question from the audience. Art, let's go with you. Was the legacy system left quote-unquote available in read-only access after migration, and for how long? Any custom portals built in the new system and services to query the old?
So since the legacy system that I currently have just handles the ancillaries and general financials as well as billing, it's an active system from a clinical perspective. There is no clinical data over there at the current time that is relevant or that would be referenced in our current EHR. So we have all the data over there for the most part and the pointers to all of the relevant data. We removed the view access from the majority of the clinicians and that from an EHR perspective, so to look at the chart, and we've only had a few instances where we've asked for return of that to certain providers, and those were in the specialty areas. So no specialty portals were created. We actually retired the access to most of the providers and have had minimal ask to have it looked at, which kind of goes to A, we did either a great conversion, or B, the data is irrelevant to them. They do know it's there and it is accessible if needed.
Rich, any thoughts?
We went largely read-only for the legacy system, again, just using that through our historical data link in the new system. However, there are exceptions to that. There are still documents that needed to be e-signed or needed to be reviewed in the old system that we kept it available to a few people. But it is actually, we found it was not nearly as straightforward to make the legacy system available in any form or fashion to clinicians as one might think. In order to make that happen, you have to make sure that the mnemonic on the old system for the user matches the mnemonic on the new system. So if you had new doctors come on, you had to go actually redefine them to the old system so they'd have access to the historical data link. A lot of things that you wouldn't instinctively anticipate out of the box. There was a very substantial maintenance effort that went into, and to some extent now continues to go into, keeping that historical data available. As we get further and further into our new system, I think that's going to be less of an issue. It already is. But it's even trying to keep it primarily read-only required an awful lot of care and feeding. I'm glad I did it. I think it's important. It's very important, but it wasn't easy.
August, any thoughts on this question?
We'll see a lot of groups go with sort of a read-only solution, especially somewhat close after go-live. However, there still is often some documentation that needs to happen in that system. So maybe the read-only might happen 6 months down the road or a couple months down the road, depending on how long the organization wants users actually actively in that system making changes. Because what we'll often see is if there's users in that system, sometimes they'll just keep going into that system unless you take away their keys. So, and if they're in that system, then a lot of times we'll want to bring over that data that's in that legacy system still. So you can kind of see a scenario where it just keeps on going and going and going. So turning that off at some point into read-only mode and then keeping it around is kind of what we've seen.
Very good. All right, last question. We're running a little long today, but we've had a lot of great audience questions, and this is a good one to end on. Rich, we'll start with you on this. What positive or negative feedback have you received from your clinicians about migrated data, and was it worth it?
Yes. Yes, it was worth it, because woe be to us if we didn't provide it. I have to honestly say we didn't get a lot of wonderful feedback about the historical data, because now you are looking at it in a separate system, for better or worse. Like I said, we converted as much as we could, but you're always going to want to go back and look at results and look at transcribed reports and things like that in an old system. And it was not because we were going from a cloud-hosted to an on-prem hosted for the historical stuff. It didn't always work quite as well as one might like, and the historical data experience was different on the acute side than it was on the ambulatory side, and we have a number of physicians who use both, so there was some confusion there. I think we got positive feedback on our efforts and our commitment to make it as frictionless as possible. I think they really did sense that their IS department as well as their leadership had their back in terms of making it better. But I won't lie, it was frustrating for them, because everything was in one place, and our goal was to have everything in one place. But as long as you're still accessing historical data from a separate place, no matter how clean you make it, it's still, well, a separate place.
All right. Art?
Yeah, I mean, echo the same comments, but one of the other things that, crops up was, some of this data that was discrete in legacy system and they want to trend out into the new system. Some of that data is just impossible to get over into discrete data, and one of our complaints was, well, why can't I trend this, or I can't look at this? Well, it's in a static data field, or it's in a report that we ended up having to scan because we could only get it that way. So one of the complaints that I knew would be happening, while they didn't ask for the legacy system, they don't want to log into two systems. They don't want to, much to Rich's comment there, he had a link over there. We did not have that. So in short, there's going to be some complaints here or there that you have to deal with, and, it's just nature of the beast. You're not going to get everything. So,
August, I'll give you the final word.
Sure, yeah, I mean, we definitely have gotten positive feedback with organizations that we've worked with and we've migrated their data for. I'd say kind of primarily just kind of echoing one of the themes that we've been talking about is when we've really focused and worked with the organization to define what needs to be brought over and what doesn't need to be brought over so that the users are not sifting through a lot of data in that new system. And I'll also add that we've gotten a lot of positive feedback about converting data via a CCD and being able to have that intermediate step where the data doesn't go directly into the patient's chart for things like problems, medications, allergies, and so forth, but that there's a kind of a step that needs to get taken by a clinician to add that data, to reconcile that data, so that if it's not relevant, it can be quickly and easily discarded. And so that's been really helpful to end users to not have to if they want to add something, they can, but if they don't want to add it, they can just discard it, and that makes it much easier for them.
Excellent. Well, that's about all we had time for today. When you close out your WebEx window, you're going to be taken to a post-event survey. If you could take a moment to answer that, we'd appreciate it. Regarding continuing education, those of you who hold the CHIME CHCIO certification get 1 credit for attending our webinars, so let CHIME know you were here, and if you've asked us to do so, we will. You'll receive an email when the archive recording of this event has been posted to our YouTube channel. If you'd like us to produce a webinar on the topic of your choice, you can reach out to Nancy Wilcox from our team, and you can go to our website to view our upcoming schedule of events. So with that, I want to very much thank our excellent panel, my good friends Art Ream and Rich Temple, and August Borie from Galen for attending and Galen for sponsoring and letting us have this wonderful event. And I want to thank you, our attendees, for always coming to our webinars. With that, everybody have a wonderful day. Thank you.
Bye-bye, everybody.